Imagine waking up from like a completely successful surgery
Right.
to fix one really debilitating structural issue, only to discover that the surgery itself instantly triggered a brand new one.
Yeah. It's a nightmare scenario.
It really is. But in the world of pelvic floor reconstruction, this paradox is, well, it's an everyday reality. A surgeon goes in to repair a severe anterior vaginal prolapse, they restore the anatomy, and the moment the patient recovers, they start experiencing stress urinary incontinence that they, never had before.
Exactly. Fixing the prolapse literally unmasks a hidden leak.
Which is wild.
Ugh.
So, welcome to this deep dive. Today we're analyzing the clinical trials, the surgical guidelines, and the biomechanical data that you need to stay ahead of the curve on this exact issue.
It's a fascinating topic.
It is. We are answering a highly debated question in urogynecology today, which is, can a mid-urethral sling surgery for stress urinary incontinence be safely combined with an anterior vaginal prolapse repair?
And the stakes for this specific surgical combo are massive. We're dealing with two heavily overlapping patient populations here.
Right.
I mean, we are looking at a prevalence of pelvic organ prolapse that hits 30% in some demographics.
30%, that's huge.
Yeah. And the occurrence of this occult or like hidden stress urinary incontinence in these patients, it's a major surgical landmine.
So to understand that landmine and figure out if combining these surgeries is a brilliant preventative measure or just, a fast track to complications, we're pulling from a pretty heavy stack of literature today.
We definitely are.
We've got the OPOS and Shupioto randomized clinical trials. We've got guidelines from the American Urological Association and position statements from the American Urogynecologic Society.
That's a lot of data.
It is. So let's just start with the mechanics of that hidden leak. Think of occult stress urinary incontinence like a kink in a garden hose.
That's a great way to picture it.
Right. So the prolapse is the physical kink blocking the water. The patient's urethral sphincter is actually already failing, but because the prolapsing bladder is physically compressing the urethra.
Pressing it like a blocked hose, yeah.
Exactly. Because of that, no urine escapes. But then the surgeon goes in, reduces the prolapse, straightens the hose, and suddenly that underlying sphincter failure becomes blatantly obvious.
And blatantly obvious. And the clinical data from the OPUS trial that stands for Outcomes Following Vaginal Prolapse Repair and Mid-Urethral Sling, it was designed specifically to address this mechanical unmasking.
Okay, so what did they actually do in the trial?
Well, the investigators randomized women undergoing vaginal prolapse repair who did not have bothersome stress incontinence symptoms yet.
Okay.
But they were at high risk for it once the anatomy was restored. They wanted to see if inserting a prophylactic mid-urethral sling right then, during the prolapse repair, would prevent that postoperative leak.
I mean, I would imagine a prophylactic sling provides some benefit, right? But given the added surgical trauma of placing synthetic mesh, the success rate would have to be, incredibly high to justify it.
Oh, absolutely.
Especially for a patient who didn't even have symptoms when they walked into the clinic.
Right, which brings us to the actual trial parameters. So the OPUS trial tracked hundreds of women across multiple clinical sites. And the UP-BIA trials out of the Netherlands ran a similar investigation, but they focused heavily on patients who demonstrated that occult incontinence during preoperative urodynamic testing.
So they were basically testing them beforehand.
Yeah, testing them with a prolapse temporarily reduced by a pessary or a swab just to simulate the surgical outcome.
Oh, that makes sense. Simulate the straight hose before you operate.
Exactly. And the results from both trials present a really compelling argument for the combo approach. I mean, if your sole metric is keeping the patient dry.
Right, which is a pretty important metric.
Of course. In the OPUS trial, looking at the 12-month follow-up data, the women who received the prophylactic mid-urethral sling alongside their prolapse repair saw a dramatic reduction in incontinence.
How dramatic are we talking?
Like 78% of the combination group reported an absence of postoperative stress urinary incontinence.
Wow.
Yeah, compared to only 39% in the group that received the prolapse repair alone.
Okay, so you are literally doubling the success rate of continence simply by anticipating that anatomical shift.
Yes, and the downstream effects of that initial success are what usually catch the attention of surgical boards.
I bet.
When you track these patients longitudinally, the need for a subsequent second surgery specifically to treat that newly unmasked incontinence, it drops from 37% down to 10%.
Wait, from 37% to 10%.
Yeah.
Okay, so if we're preventing a second trip to the operating room for 27% of these patients, shouldn't the prophylactic sling just be the standard of care? It's like across the board.
You would think so, right?
Yeah, I mean, if the data shows it keeps people out of the OR, the debate should be over.
Well, the debate exists because preventing a second surgery for incontinence
Yeah.
inadvertently increases the risk of needing a second surgery for a severe surgical complication.
Oh, okay.
Yeah. The combined procedure fundamentally alters the safety profile and the pelvic anatomy in ways that force a very difficult risk-benefit analysis.
So what are the actual risks here?
When you pool the safety data from these trials, the risk of serious adverse events, SAEs, it jumps considerably.
Define considerably.
Depending on the specific multi-center data sets, the SAE rate increases from 8% to 14%, or in some OPUS parameters, from 12% up to 16% when the sling is added.
A 16% serious adverse event rate is not just a minor statistical blip,
No, it's not.
because the guidelines classify an SAE as like a complication requiring an invasive procedure, a reoperation, or resulting in organ system failure. Right?
Exactly. We're talking about major morbidities here.
Right.
Things like bladder perforations during the initial dissection, long-term voiding dysfunction where the patient actually has to self-catheterize,
Oh, wow.
and mesh exposure where the synthetic material fails to integrate and essentially erodes right through the vaginal epithelium.
Okay, so to understand why a prophylactic sling triggers these severe complications, we have to look at the altered biomechanics of the surgical field.
Right.
Abstract 433 in our source stack analyzed the risk factors for mesh revision and highlighted the tissue mechanics of an anterior colporrhaphy.
Which is the standard repair for an anterior vaginal wall prolapse.
Right, so let's break down the mechanics of that specific repair. Because during an anterior colporrhaphy, the surgeon dissects the vaginal epithelium away from the underlying fibromuscular layer, right?
That's the first step.
Then they plicate or fold and suture the pubocervical fascia to basically pull the herniating bladder back into place and reinforce the tissue.
Exactly. And that pintication process fundamentally changes the physical properties of the anterior vaginal wall.
How so? Well, you are creating structural tension to fix the prolapse, which significantly decreases the elasticity and mobility of that tissue.
Okay.
But more importantly, the extensive dissection and suturing alter the local vascular bed. It creates localized ischemia, which is a reduction in blood flow.
Which brings us right to the biomechanical conflict.
Yeah.
Because you are performing that anterior colporrhaphy, creating this tensioned ischemic environment.
Yes.
Then, in the exact same operation, you are making additional incisions into that exact same compromised area to insert a mid-urethral sling.
You're right.
And that sling is made of macroporous synthetic mesh, which requires healthy native tissue ingrowth fibroplasia to secure it, doesn't it?
It does. The physiological demand on the tissue is immense here.
I can imagine.
Fibroblasts need a robust blood supply to deposit collagen into the pores of the mesh. And macrophages need that same vascular network to clear out bacteria.
So if there's no blood flow, exactly. When you place synthetic mesh into a heavily trafficked ischemic surgical field, the tissue simply doesn't have the biological resources to integrate it. This failure of integration is the primary driver behind mesh extrusion and erosion.
It's almost like it's like trying to anchor a heavy load-bearing mirror into drywall that has already been water damaged and heavily patched up.
That is a perfect analogy.
Right. Like, it doesn't matter how good the anchor is, the surrounding structural integrity is just completely compromised. The tissue doesn't have the capacity to heal from two competing structural interventions in the exact same anatomical zip code.
Absolutely. And the distorted anatomy also explains the higher rate of bladder perforation we mentioned earlier.
Oh, because everything is shifted around.
Yes. The anterior colporrhaphy alters the normal anatomical landmarks and planes. So when the surgeon then passes the trocars to place the mid-urethral sling, they are navigating a field where the bladder is no longer sitting in its predictable native position.
The paradox in the data here is that tissue trauma and anatomical stability dictate these complications, right? Which makes the specific type of mid-urethral sling the surgeon chooses the ultimate deciding factor.
Yes, the specific type matters immensely. We see this clearly in a retrospective analysis published in the Canadian Journal of Urology.
Okay, what did they find?
The researchers compared the outcomes of two distinct mid-urethral sling designs used during these combo surgeries. single incision slings and retropubic slings.
And the structural differences between these two are pretty critical here. I mean, a single incision sling relies entirely on local tissue for anchoring.
Right.
The surgeon inserts it through a single vaginal incision, and the device anchors into the obturator internus muscle, or like the dense fibrous tissue of the urogenital diaphragm,
Okay.
which are structures immediately adjacent to the urethra.
Exactly. Whereas a retropubic sling uses a completely different trajectory.
Right.
It passes up behind the pubic symphysis and anchors into the rectus fascia way up in the abdominal wall.
So they're anchoring in totally different zip codes.
Very different. And the Canadian study revealed a massive discrepancy in how these two slings perform when the pelvic floor is already traumatized.
Let's hear the numbers.
Well, when performed as a standalone procedure for incontinence, so no prolapse repair, single incision slings demonstrate excellent efficacy. The study recorded an 89% success rate.
That's great.
It is. But the moment that single incision sling is combined with an anterior prolapse repair, its success rate plummets to 67%.
Wait, down to 67%. That's a huge drop.
It's significant, yeah.
What about the retropubic approach? Does it drop too?
Actually, the retropubic approach completely circumvents that drop in efficacy. The data shows retropubic slings maintaining a 93% success rate as a standalone procedure and a 94% success rate when combined with a prolapse repair.
So the combination doesn't degrade its performance at all.
Not at all. And the authors point directly to the biomechanical anchoring planes to explain this failure rate.
Right, because of where it's anchoring.
Exactly. The single incision sling requires stable, intact local tissue, specifically the urogenital diaphragm and surrounding fascia, to grip into. But during an anterior colporrhaphy, the lateral dissection often inadvertently disrupts this exact anchoring zone.
So the surgeon is trying to anchor the single incision sling into tissue that has just been structurally weakened by the prolapse repair itself.
Bingo. The retropubic sling bypasses that traumatized field entirely.
Because it goes higher up.
Right, because it passes through the retropubic space and anchors higher up in the abdominal fascia.
Well,
It doesn't rely on the compromised anterior vaginal wall for its structural stability at all.
it finds pristine tissue to anchor into.
Exactly. Which is why it provides superior, reliable support even when the lower pelvic floor is undergoing major reconstruction. Based on this structural reality, many urogynecologists have entirely abandoned single incision slings for combined procedures, opting exclusively for the retropubic approach.
But selecting a retropubic sling inherently means discussing synthetic transvaginal mesh.
It does.
Which brings us to a highly complex regulatory and public health environment. You cannot evaluate this clinical data without addressing the massive public fear surrounding mesh implants and how that fear impacts the patient sitting in the exam room.
It's a huge factor in the clinical experience right now.
Because there is so much conflicting information and, well-documented litigation surrounding transvaginal mesh, the patient is incredibly vulnerable when navigating these surgical options.
Absolutely.
The American Urogynecologic Society, AUGS, released position statements specifically to clarify the science for policymakers and obviously for patients facing these choices.
And AUGS emphasizes a critical distinction that is so often lost in the public narrative.
Right, about what the FDA actually banned.
Yes. The highly publicized FDA warnings and the subsequent removal of certain products from the market were targeted at transvaginal mesh used for prolapse repair.
Prolapse repair, not the slings.
Exactly. The warnings were not directed at mid-urethral slings used for stress urinary incontinence. Mid-urethral slings remain the global gold standard for incontinence.
They're completely different materials.
Well, the structural properties of the mesh used, the amount of mesh implanted, and the anatomical placement are entirely different.
Even with that clinical distinction, though, AUGS has taken a very firm stance against legislators and insurance providers attempting to implement blanket bans on all transvaginal synthetic mesh.
They have. And their clinical rationale focuses entirely on patient outcomes and anatomical reality.
Because native tissue repairs aren't perfect either, right?
Far from it. No single surgical approach works for every pelvic floor. Native tissue repairs, where the surgeon only uses the patient's own fascia to fix the prolapse without mesh, they carry significant risks of their own.
Like what?
Well, the recurrence rate for native tissue anterior colporrhaphies can be exceedingly high, sometimes exceeding 30%.
Wow, a 30% failure rate is massive.
It is. If a patient has already experienced a failed native tissue repair, stripping away the option of synthetic mesh removes the surgeon's ability to individualize care for a high-risk patient. AEGS maintains that these materials must remain available, provided the procedures are performed by credentialed specialists who truly understand the intricate biomechanics of the pelvic floor.
This whole regulatory and clinical landscape, it just places an immense cognitive burden on the patient.
Oh, completely.
I mean, think about it. They are dealing with a complex anatomical issue, facing a surgery with a 14% risk of severe adverse events, and navigating public fear about the materials being implanted.
Overwhelming.
It really is. And how a surgeon counsels a patient through those statistics directly alters their physical recovery.
It does.
The Kenton study in our source stack measured the precise impact of patient preparedness on surgical outcomes.
Yeah, the findings in the Kenton study really reframe how we view preoperative counseling. It is not just an administrative requirement for informed consent, it is a clinical intervention.
That's a great way to put it, a clinical intervention.
Yeah. The data demonstrated that increased patient-reported preparedness is directly associated with improved objective surgical outcomes, superior symptom improvement, and a higher quality of life post-operation.
So the psychological framing of the risk alters the physiological and psychological experience of the complication itself.
Exactly. When a surgeon breaks down the exact trade-offs, like explaining the biomechanical reasons why the combo surgery carries a 14% chance of an SAE, like voiding dysfunction, versus a 28% chance of waking up with severe stress, urinary incontinence if they skip the sling.
Right.
The patient moves from being a passive recipient of a medical procedure to an active participant in their own risk management.
They are forced to evaluate their personal risk tolerance.
Yes.
So if a highly prepared patient chooses the combination surgery to guarantee continence, and they experience, say, transient voiding dysfunction requiring a catheter for 3 minutes, they don't view the surgery as a catastrophic failure.
Exactly. They anticipated the compromised tissue healing. They accepted that specific risk to avoid incontinence, and they have the psychological resilience to manage the recovery.
Right. Conversely, if a patient prioritizes a faster, lower-risk anatomical recovery, chooses a native tissue repair without the sling, and wakes up with unmasked stress urinary incontinence, they aren't blindsided.
No, because they understand the mechanical barrier of their prolapse was removed, and they are mentally prepared for the second surgical step.
The feeling of being prepared literally changes the post-operative morbidity metrics.
It really does.
So if we synthesize this whole deep dive into the combination of mid-urethral slings and anterior vaginal prolapse repairs, it seems like the literature provides a definitive yes, but.
Very much so. The combination effectively eliminates occult stress urinary incontinence, but it requires operating in a heavily compromised ischemic surgical field.
You're balancing the high probability of postoperative leaking against a statistically significant increase in wound healing failures, mesh erosions, and bladder perforations.
Right. And if the combination is structurally necessary, the biomechanical data dictates that a retropubic sling, which anchors outside the traumatized surgical zone, is vastly superior to a single incision sling.
And navigating these trade-offs requires a level of preoperative counseling that acts as a true clinical intervention, basically empowering the patient to dictate their own risk tolerance.
Perfectly summarized.
You know, throughout this deep dive, we've explored how fixing a prolapse, straightening out that mechanical kink, instantly unmasks a hidden urethral leak. And to me, it highlights a pretty profound reality about human anatomy.
What's that?
The body is not a machine made of isolated independent parts. It operates as a tensegrity structure.
A tensegrity structure.
Yeah, tensegrity, tension, and integrity. It means the system is stabilized by a continuous web of tension. If you plicate the fascia and pull a structural string tightly on the vaginal wall, it instantly changes the tension, the blood flow, and the mechanical load on the urethra.
Well, that's incredibly accurate.
Right. Everything is bound together in this dynamic architectural web. And as we move away from the era of isolated, single-organ surgical fixes, perhaps the future of predictive medical modeling won't just focus on the single organ that is failing.
It'll look at the whole system.
Exactly. The real breakthrough will lie in mapping the entire tensegrity structure of the human body, allowing surgeons to computationally predict exactly what will happen across the entire system when they pull just one string. Just something to analyze the next time you look at a complex, interconnected system.